Welcome! In this explainer, we're going deep on a disease that often flies under the radar, passed from animals to people, usually through something as simple as contaminated water. We're talking about leptospirosis. We're going to walk through its clinical journey, all the way from a fever that looks like anything else to a multi-organ threat that can leave its mark for years.
So let's start with a clinical puzzle. What do all these things have in common? A farm animal, some contaminated water, and a patient with a dangerous fever. Well, this isn't just a riddle. This connection is the absolute key to understanding how the bacterium we're talking about today moves, and why it's so dangerous.
All right, let's dive in. You know, the first huge challenge with leptospirosis is just spotting it in the first place. It is a master of disguise. So imagine a patient walks into the clinic. This is where we start trying to piece things together. Because what we're looking for isn't one single presentation, but a whole spectrum, from something that feels like the flu to a full-blown medical emergency.
Okay, so what exactly is leptospirosis? It's a bacterial infection caused by a spirochete, a type of bacteria from the genus Leptospira. And its spiral corkscrew shape is not just for looks, it's what lets it literally drill its way into tissues. Now, it's not one single bug. There are over 300 known serovars, or strains. After someone's exposed, the bug usually incubates for about 1 to 2 weeks, but that window can be really wide, sometimes as fast as 2 days or as long as a month.
The way this disease shows up can be wildly different from person to person. On the one hand, you have milder forms. You might hear them called things like mud fever, often passed from mice, or milk fever from cattle. These can look just like the flu. But on the other end of that spectrum, you have the severe form, Weil's disease. This is the life-threatening version, and it's classically linked to serovars that are carried by rats.
So let's imagine our patient has this severe form. The onset of Weil's disease is incredibly abrupt and intense. It kicks off with a sudden, spiking fever, then comes this awful muscle pain, classically felt deep in the calves. We're also seeing chills, abdominal pain, vomiting, and really severe headaches. And here's a key clinical sign to look for: conjunctival vascular injection. That's bleeding into the whites of the eyes. And in about half of these severe cases, the liver actually becomes large enough that you can feel it.
Okay, so with this set of symptoms, you have a very high suspicion. But you need to confirm it. You need to crack the case in the lab. And how we do that really boils down to one critical factor: timing.
The diagnostic pathway is basically a race against the patient's own immune system. For about the first 10 days, what we call the bacteremic phase, the spirochetes are actively circulating in the bloodstream. So our best bet is direct detection using a highly sensitive real-time PCR test on a blood sample. But after day 10, the bacteria are mostly gone from the blood because the body's starting to fight back with antibodies. So our strategy has to flip. We switch to indirect detection, using serology to look for those specific antibodies.
And even within serology, there's this classic trade-off. Think of the ELISA test as casting a very wide net. It's super sensitive, so it's unlikely to miss a case. But the downside is, it can sometimes cross-react with other infections like CMV or EBV. Then you have the microscopic agglutination test, or MAT. This is the gold standard, our specific spear. It's less sensitive, but if you get a positive, it's definitive, because you are literally seeing the patient's antibodies cause live bacteria to clump together under a microscope.
So, we've talked about what this thing does and how we find it. Let's take a closer look at the microbial culprit itself, the Leptospira bacterium. As I mentioned, Leptospira are spirochetes. And to give you some context for that, this family of bacteria includes some pretty infamous relatives. They're related to Treponema, the bug that causes syphilis, and Borrelia, which is responsible for Lyme disease. So that alone should give you an idea of the kind of invasive, persistent pathogen we're dealing with here.
You know, there's a little bit of clinical humor that perfectly sums up this bacterium's entire purpose. Why did the Leptospira cross the road? To get to the other host! And it's funny because it's true. Its whole life cycle is just geared toward transmission, moving from an animal reservoir, surviving in the environment, and finding its way into a new host.
Right, so once we have a positive identification, the focus has to shift immediately to intervention. The treatment protocol is really a two-pronged attack, going after both the infection itself and the systemic damage it's causing.
The first, and maybe most critical prong of treatment, is just aggressive supportive care.
This spirochete can cause massive damage to the lining of blood vessels, making them leaky. So you have to manage the fallout from that. Things like kidney failure and dangerously low blood pressure. That is paramount. The second prong, of course, is antimicrobial therapy. The go-to antibiotic is doxycycline at 100 milligrams twice a day for 7 days to kill the bacteria itself.
Now, here's a really critical point I need to make. The source material we're looking at gives us a clear protocol for adults, but it does not lay out specific treatment regimens or dosages for children. This highlights a really important gap where clinicians have to rely on their own specialized pediatric expertise.
Okay, let's zoom out from the individual patient for a minute, because containing a disease like leptospirosis isn't just about treating one person. It requires a coordinated public health response.
Leptospirosis is what we call a notifiable disease. And that means the moment it's confirmed, a clock starts ticking. Public health authorities require both the diagnosing lab and the treating physician to report a case within just 1 working day. That urgency is absolutely vital for tracking down the source and preventing a wider outbreak.
Now, the risk for this disease isn't spread evenly. It's really concentrated in occupations that are on the front lines of that human-animal environment interaction. We're talking about farmers, veterinarians, sewage workers, even construction workers and pest controllers. They all share a much higher risk because of their potential contact with infected animals or contaminated soil and water.
So prevention really comes down to building barriers at every possible level. It starts at the source with things like effective rodent control to reduce the amount of bacteria in the environment. For those high-risk jobs, personal protective equipment is the next critical layer. And then for everyone, it comes down to personal vigilance, basic hygiene, making sure you cover any open cuts or scrapes, and just being cautious around dead animals or bodies of water that might be contaminated.
Finally, let's talk about the potential outcomes. Because even with the best treatment, an infection with leptospirosis can have serious and sometimes lasting consequences. This chart really shows this severity funnel. While most infections are probably quite mild, a small fraction, we're talking less than 1%, will progress to that severe disease that requires hospitalization. And then, of those severe reported cases, about 3% end up being fatal. Death is usually from that combined assault of kidney failure, jaundice, and internal bleeding.
But here's the thing. Recovery from the acute illness isn't always the end of the road. And this statement from the source material is really compelling. It says that while complete recovery is likely, persistent symptoms such as malaise, fatigue, and depression have been described for months to years post-acute illness. It casts a long, debilitating shadow.
And that really brings us to our final question. In a world where climate change is altering water patterns and our cities and suburbs are pushing further into wild spaces, the conditions for diseases like leptospirosis are getting better and better. So we have to ask, is this so-called forgotten fever a threat that we really can't afford to ignore anymore?